Got Billy? Well, if you're jaundiced, yeah, you do. In a nutshell, jaundice is the visible exam finding resulting from having too much bilirubin floating around in the blood, aka hyperbilirubinemia. This sketch will focus on the many different causes that can come about. Get ready to hear about conjugated and unconjugated bilirubin, urobilinogen, alkaline phosphatase, gamma-glutamyl transpeptidase, Dubins and Johnsons and Gilbert's. Don't worry, we're going to break down hyperbilirubinemia into three major categories. Disorders that result in lots of conjugated bilirubin in the serum versus lots of unconjugated versus lots of both. Before we dive into the causes of hyperbilirubinemia, let's quickly go through the normal production and metabolism of bilirubin. Bilirubin is produced by the breakdown of heme, a natural process occurring all the time as your red blood cells, or RBCs, progress through their natural lifespan, which is about 120 days. Heme is made up of a porphyrin ring of carbons and nitrogens surrounding an iron atom, kind of like the molecular spokes surrounding the iron hub of this wagon wheel. After getting eaten up by macrophages in the spleen, iron gets recycled while the porphyrin ring is converted to unconjugated bilirubin. At Sketchy, bilirubin is embodied by a billy goat. And since we're still inside those spleen macrophages, we've put the billy goat in its pen, a macro cage. Next to that oddly spleen-shaped sack of feed, no less. Now, a quick word about conjugated and unconjugated bilirubin. Whenever we talk about conjugated, the billy goat will be collared and on a leash. Good boy. If the bilirubin is unconjugated, well, that's a billy goat unleashed, like the bilirubin left over after breaking down heme. Unconjugated bilirubin means that it's lipid soluble, and that means it doesn't play well with blood. You see that uncollared billy goat running by with that album? In order to move around in the circulation, unconjugated bilirubin is bound to albumin and transported to hepatocytes, the site of all bilirubin metabolism. Bad pun count starts now. If unconjugated bilirubin were excreted in its natural form, its lipid-soluble nature means it would just be immediately reabsorbed in the gut, creating a vicious bowel loop. Loop. Number 2, count it! Fortunately, liver processes such as oxidation, reduction, and conjugation makes these lipid-soluble molecules water-soluble and ready for excretion. In the case of bilirubin, phase 2 conjugation to glucuronide via UDP glucuronal transferase turns unconjugated bilirubin to conjugated bilirubin. UDP glucuronal transferase? Sounds like a good old-fashioned glucuronal goat ride to me. Yeehaw! Now that bilirubin is conjugated to glucuronide, it's more water-soluble and thus easier to pass via a good number 2. Because it's, phase 2? In the intestines, this conjugated bilirubin is converted by intestinal flora to urobilinogen, or UBG. Urobilinogen has 2 potential fates at this point. Some is oxidized in the gut to stercobilin, represented by the sterco billy goat stuck in the mud. Stercobilin is passed in the stool and is responsible for the brown color of poop. The rest of urobilinogen is reabsorbed into the bloodstream and either returned to the liver, hence the liver spot, or excreted via the urine, hence the pee party going on there. Urobilin, or more awesomely called urochrome, is responsible for the normal light yellow color of urine. Let's set up this scene. Just like renal disease has pre, intrinsic, and post-renal causes of dysfunction, you can think of the liver as a bilirubin processing plant that also has various characteristic breakdown points. Remember, unconjugated bilirubin floats around in the circulation bound to albumin before it's conjugated by the liver and kicked out into the bile. Therefore, in a normal state, you'll see some bilirubin in the serum at all times. Just expect almost all of it to be unconjugated. We approach disorders of bilirubin metabolism by first measuring total bilirubin, which is a combination of both conjugated and unconjugated bilirubin. Then we measure conjugated bilirubin specifically to see how much it contributes to the total. Conjugated is also called direct bilirubin, so this ratio is called the direct bilirubin fraction. Again, because there's mostly unconjugated bili in the serum, the direct bilirubin fraction is normally low. This ratio is what we're going to use to figure out where the breakdown in metabolism is. When there's an abnormally high amount of bilirubin in the blood, it's called hyperbilirubinemia. There can be lots of conjugated, which we'll show on the right side of the fence, lots of unconjugated, which will be on the left side of the fence, and lots of both, which you may have guessed will be right on the fence. These three groups are separated by their direct bilirubin fraction. Unconjugated hyperbilirubinemia with a low direct bilirubin fraction, usually under 20%, conjugated hyperbilirubinemia with a high direct bilirubin fraction, which means somewhere over 50%, and then there's mixed hyperbilirubinemia in that gray area between 20 and 50% direct bilirubin. Let's start on the left side of the fence with a few clinical scenarios when you'll see lots of unconjugated bilirubin accumulating in the blood. Unconjugated means no leash or collar, of course. So these billy goats are going cray-cray. Take that, tomatoes. The first cause of unconjugated hyperbilirubinemia to discuss: hemolysis. Imagine this. Your red blood cells are breaking down at an accelerated rate, either because of a hemoglobinopathy, think thalassemias or sickle cell disease, or there's some kind of red blood cell structural disorders, such as spherocytosis or ellipsocytosis, or an RBC enzyme deficiency, like G6PD deficiency, or maybe an immune-mediated hemolytic anemia. Whew, lots of possible causes of hemolysis, all covered in our upcoming hemolytic anemia sketch. Well, when RBCs are breaking down, macrophages clean up the mess and produce a bunch of unconjugated bilirubin, which gets released into the circulation. So that explains the uncolored billy goat there wreaking havoc. There's more to this story, however. Lots of unconjugated in the circulation means lots of unconjugated reaching the liver to be conjugated and excreted in the bile. Like we discussed before, bile billy gets turned into urobilinogen, which is reabsorbed to the bloodstream and peed out at the kidneys. That's that little guy there, the little PP urobilinogen goat. In summation, when there's an overproduction of unconjugated bilirubin from lysing RBCs, imagine a concomitant acceleration of the entire bilirubin metabolic pathway, culminating in the final form: urobilinogen getting excreted by the kidneys, his little PP sidekick. Instead of overproducing unconjugated bilirubin, what if we have a normal amount being produced, but once it gets to the liver, there's a problem with its metabolism? Again, unconjugated bilirubin starts to build up in the serum. This occurs in Gilbert syndrome, an autosomal recessive disorder caused by decreased activity of UDP glucuronal transferase. This is represented by Farmer Gilbert here, who can't quite keep up with these unruly goats. See how old Gil wants to put the leash on the goat, collar it, conjugate it, if you will, but he's too slow? It's kind of like how the conjugating enzyme of the liver is too slow, allowing unconjugated bilirubin to accumulate in the serum. Gilbert syndrome follows an autosomal recessive pattern, hence the recessive shy kid hiding behind his mom. And I can tell she's trying to recall all that fine print at the bottom of the waiver she signed earlier. But don't worry, Gilbert syndrome is completely benign, and in most cases, diagnosis is usually made by an incidentally elevated bilirubin level on routine lab testing. Remember, this will come up as a low direct bili fraction. We're talking unconjugated here. The vast majority of these patients are asymptomatic. If anything, mild jaundice can be seen during times of stress, such as fasting, hypovolemia, extreme exercise, emotional goat trauma, the usual childhood stressors. No big deal, right? Well, on the opposite end of that severity spectrum is Crigler-Najjar syndrome, which can be life-threatening. For Crigler-Najjar, think cricket in a jar. Score! Crigler-Najjar is an autosomal recessive disorder. Hence our proximity, yet again, to that recessive shy kid, who by now I'm sure has developed a lifetime goat phobia. Instead of decreased enzyme activity, Crigler-Najjar involves a deficiency of UDP glucuronal transferase. So instead of slow conjugating enzymes, we're dealing with a severe lack of enzymes. With an inadequate amount of UDP glucuronal transferase, bilirubin is unable to be conjugated and excreted in bile. No Farmer Gil, no collar, just a stampede of unconjugated billy goats. This quickly leads to unconjugated hyperbilirubinemia and marked jaundice within the first few days of life. While Crigler-Najjar type 2, in which there's only a partial deficiency of UDP glucuronal transferase, is less severe, type 1 can lead to marked hyperbilirubinemia. Unconjugated bilirubin heads to the brain to cause cell death, leading to encephalopathy, brain damage, or death if not diagnosed and treated early. When acute encephalopathy causes irreversible neurologic dysfunction, this is called kernicterus, symbolized by the jaundiced ears of kernicterus corn in the back. Let's move on to a few forms of unconjugated hyperbiliry that are completely physiologic and usually don't cause harm. These conditions occur in the first few weeks of life. We'll start with the most common form, physiologic jaundice of the newborn. Infants, being terrible at pretty much everything, no offense, babies, have less capacity to metabolize bilirubin than adults for two reasons. One, their tiny little baby livers have decreased UDP glucuronyltransferase activity, and two, their brand new baby guts don't yet contain much intestinal flora, which are essential to the conversion of bilirubin to urobilinogen. In addition to lowered capacity, newborns make extra bilirubin. They go through a normal period of transition during which their macrophages destroy fetal remnants, like fetal RBCs, and also produce extra bilirubin as a result of the shortened lifespan of their neonatal RBCs, which is 60 to 90 days. This buildup of unconjugated bilirubin leads to jaundice in the first few days of life. It's quite a common finding in neonates and usually lasts less than 2 weeks. Treatment is often not needed, but when it is, simple phototherapy with blue light converts the naturally occurring fat-soluble trans isomer of bilirubin into cis-bilirubin, which is water-soluble and easily excreted via urine or stool. Wait, I guess it'll do. The other two forms of physiologic hyperbilirubinemia in neonates can be easily mixed up, so listen carefully. There's breastfeeding jaundice and breast milk jaundice, which you'll see in exclusively breastfed babies. Breastfeeding jaundice should be more accurately labeled lack of breastfeeding jaundice. Breastfeeding jaundice actually occurs because of a lack of breast milk production in the mother, most often breastfeeding mothers who just had her first baby. Less food in the tummy means less impetus to move the bowels. In the sluggish gut, conjugated bilirubin that's just sitting around can deconjugate. This unconjugated bilirubin gets recirculated from the gut back to the liver, aka enterohepatic circulation. This results in a buildup of bilirubin and subsequently jaundice. Just like physiologic jaundice of the newborn, breastfeeding jaundice is not harmful to the baby, and time or formula supplementation will return the baby's skin to normal. So breastfeeding jaundice is early, as in seen in the first few days of life, which is in contrast to